Scapulothoracic bursitis or crepitus, also known as snapping scapula, may range in severity from a simple annoyance to a truly disabling condition for the symptomatic patient. The crepitus is usually described as a snapping, popping, or grinding sound, and on physical examination, it may be associated with a sensation of fullness or prominence with palpable or audible grating. Bursitis is more often due to repetitive overuse from overhead activities. Physical examination findings include point tenderness over the area of the involved bursa and pain with range of motion. Scapulothoracic crepitus and bursitis have been attributed to a number of findings, including anatomic anomalies between the scapula and chest wall, osteochondromas, Luschke's tubercle, a prominence of bone at the supromedial aspect of the scapula, an excessively hooked supromedial aspect of the scapula, malunions of the scapula or ribs, reactive bone spurs, infectious etiologies, or incongruity of the articulation secondary to scoliosis or kyphosis. In the workup, radiologic studies include plain X-rays, CT with or without 3D reconstruction, and MRI. A local injection of steroid may serve both diagnostic and therapeutic goals. The mainstay of treatment is non-operative. The exception is structural lesions, which are more resistant to non-operative treatment and oftentimes need to be excised. An understanding of the anatomy is important when treating these problems. There are two major bursa. The scapulothoracic or infraserratus bursa is the most common and is located between the serratus anterior muscle and the chest wall. The subscapularis or supraserratus is located between the subscapularis and serratus anterior muscles. There are four minor bursa which are not consistently found. Two are located at the supromedial angle and may be either infra or supraserratus. Another is located at the inferior angle of the scapula and is infraserratus. And the fourth is the scapulotrapezial or trapezoid, which is located at the medial base of the spine of the scapula underlying the trapezius muscle. There are three nerves about the scapula, namely the dorsal scapular nerve, the spinal accessory nerve, and the suprascapular nerve. These are important when placing portals. To avoid injuring the main branch of the dorsal scapular nerve, both portals are placed inferior to the spine of the scapula. Arthroscopic treatment was introduced by Ciolo in 1992, and the first reported series was by Harper in 1999, which consisted of bony debridements of the supromedial angle. The patient treated in our video today is a 20-year-old right-hand dominant female with a history of scoliosis who underwent spinal release and anterior and posterior fusions, as well as a right-sided thoracoplasty in 2000. She subsequently developed right-sided symptomatic scapulothoracic crepitus and was treated with a partial resection of a posterior rib in 2002. She noted some improvement, although incomplete, following the partial rib resection for approximately 2 years postoperatively. However, in the 3 months prior to presenting to our office, she developed worsening, recurrent complaints. She complained of moderate pain and difficulty sleeping. A CT scan and MRI were performed, which were consistent with scapulothoracic bursitis and bony impingement superiorly at the supromedial angle of the scapula. The symptomatic area is marked out preoperatively. Once general anesthesia has been administered, the patient is placed in a prone position. The extremity is draped and draped in the usual sterile fashion. The scapular margins, as well as the orientation of the nerves about the scapula, are marked out using a sterile marking pen. In this patient, the scars from her previous surgeries are dotted with a marking pen. The affected extremity is then placed in an extended and internally rotated position to wing the medial border of the scapula, also known as the chicken wing position. Approximately 100 cc's of normal saline with Marcaine and epinephrine is used to distend the scapulothoracic joint and for hemostasis. This allows for safer introduction of the arthroscopic instruments. First, a portal is established at the inferior medial angle and a 4 mm 30-degree scope is inserted. A diagnostic arthroscopy is performed. Extensive severe scapulothoracic bursitis was noted in this case. There was also evidence of bony impingement at the supromedial angle of the scapula. A second mid-medial portal can be established by triangulating with a spinal needle. To assist with orientation, the intercostal muscles and ribs should be visualized inferiorly, the subscapularis laterally, and the rhomboids and levator scapula medially. Red muscle fibers should not be resected. A shaver and radiofrequency probe are then inserted to remove the bursa, to enhance visualization, and to skeletonize the supraromedial angle. An endoscopic scapuloplasty is then performed. A high-speed motorized burr is used to resect the supraromedial angle. The resection is performed similarly to an arthroscopic acromioplasty with approximately 20 by 20 millimeters removed, and the resection is viewed from both portals to ensure adequacy of resection. The bone is typically thin, and a rasp may be used to contour to a smooth, stable, and flat margin. The arm is then brought through range of motion to assess the resection. Under direct visualization, a pain pump is inserted into the scapulothoracic space. The portals are closed in a routine fashion, and the surgery is typically performed as an outpatient procedure. Our rehabilitation program consists of early range of motion, both actively and passively, of the glenohumeral joint, as well as scapular protection and retraction. A sling is used for comfort only. At 4 weeks, isometric strengthening of the glenohumeral joint is initiated, and at 8 weeks, parascapular strengthening is initiated. Potential complications from arthroscopic scapulothoracic surgery include pneumothorax, neurovascular injury, and failure to resect all pathologic tissues. To our knowledge, there are no published reports of these complications, although the experience is still in its infancy. A CT scan was performed postoperatively to determine the adequacy of resection. At 6 months postoperatively, this patient is asymptomatic.